You may have a very severe disease condition or even severe dehydration. There are various things that can cause your kidneys to fail to function. Okay, so when you have acute kidney failure, for some of those patients, sometimes a couple of sessions of dialysis, the kidney is able to recover and they're able to continue their lives normally without needing further dialysis.
Hi, good day and welcome to another edition of the Lowdown here on GhanaWeb TV. My name is Daniel Ojo. Today we just have the privilege of interviewing or speaking to the Chief Executive Officer of Korle-Bu Teaching Hospital, the premier teaching hospital in Ghana. And we just got off a press briefing as to do with kidney transplantation in Ghana. And all the speakers said it was the vision, or it is the vision of the CEO, Dr. Opoku Ware Ampoma. Doc, thank you very much for your time. I know you're very busy, man.
You're most welcome.
We just finished a press briefing on kidney transplantation, which happened in July, and I'm told there's another one in August. But what struck me was the fact that all the speakers said this is the, if you like, an important thing for the CEO. How big is transplantation for you as CEO of Korle-Bu Teaching Hospital?
Thank you very much. Thank you for your kind words, but I believe that is a shared vision because I think there are members of various teams within the hospital who, after studying and getting experience in various disease conditions, are aware that transplantation is one of the options that is available elsewhere around the world, which is still not available for Ghanaian patients. And so it's been our vision to make sure that we develop and enhance our services to the extent that any patient with whatever condition does not have to travel abroad for those services. And so transplantation is one of them. And so we decided to focus on the renal transplantation since some work had already been done by my predecessors. I thought that it was high time that we took it a step further. And so what we are celebrating is the fact that this time it was a fully Ghanaian team that performed the transplant, and that we're going to have it as part of the regular services that we offer in this hospital. And I believe that it's an important addition to the healthcare delivery system in this country because we have about 1,000 Ghanaian patients who are on regular dialysis. Dialysis means that their kidneys are not functioning. They have to be hooked up to a machine about sometimes 3 to 4 times every week, so that the waste products in their blood can be filtered out. And this comes at a huge cost, huge inconvenience to them. And so if they have the option of receiving a kidney transplant, then they will have a functioning kidney and they will not need to be coming for dialysis. So this, apart from the being cost effective, is also life enhancing for the patients.
Okay. But is it everybody who has a kidney failure who is a potential candidate for a transplant?
Okay, so we have different types of kidney failure. So we have something called acute kidney failure and then chronic kidney failure. So you may have a very severe disease condition or even severe dehydration. There are various things that can cause your kidneys to fail to function. Okay, so when you have acute kidney failure, for some of those patients, sometimes a couple of sessions of dialysis, the kidney is able to recover and they're able to continue their lives normally without needing further dialysis. So for those who are, require dialysis, require transplantation, are those who have what we call chronic kidney failure, where the kidneys have literally not really functioning well and they need to be supported by having regular dialysis, lifelong dialysis. And so the only way that they can stop having dialysis and still live is to have a kidney transplant. And so this is the kind of service that we are bringing on board.
Okay. So kidney transplants appears to be what we've mastered. But are there other transplants that we do? I hear cornea transplants. I hear other transplantations. do we do those things at Korle-Bu, or is just kidney for now?
Yes, so our ophthalmology department actually also does corneal transplants.
Okay.
The only caveat there is that because we do not have a tissue transplantation act,
right?
That's any enabling legislation to enable us to harvest some of these organs. So previously, the corneas have come from abroad, okay, at a huge cost, and also basically we fall on our colleagues abroad to facilitate some of these things for us. But there are other organs that can be transplanted, like the liver, the heart, several other organs can be transplanted. Okay, and so once we have that enabling legislation, then this will enable us to be able to do some of these things. For the kidney transplantation, we're able to start it because everybody has got 2 kidneys. Okay. So you can donate 1 kidney, and if you're a normal healthy person, the other kidney that you have is enough to cater for your own needs. Okay, because if in a healthy person, you can survive on a quarter of one kidney.
But the cynics will say there's a reason God gave us 2.
Exactly. So God built a lot of redundancies into our system, meaning that we have a lot of excess capacity. Okay. But if you take some other organs like the heart and the liver, for instance, you only have 1, so you cannot donate. Exactly. Of course, sometimes there's in the case of the liver, you can do a partial liver transplant, say from an adult to a child, a small child. It can be done. But then generally, for most of these other organs, the living person needs that organ as well, so they cannot donate it, and still survive. But the kidney is one of the organs where you can donate 1 kidney and still have a spare that you're using yourself, and so that's why we started the kidney transplant program. And so currently, what it is that somebody who's either related to the donor or who knows the donor by his the blood types are compatible, etc., is the one who donates one of their kidneys to the patient. Okay. And so that is what we are practicing now. Okay. But what we are saying is that if we have enabling legislation, so other countries have done that, and we can also follow suit, where we can have an organ transplantation program and have a law which allows people to sign up, and say that, look, in the event of my death, you can harvest my organs and use it to save another life, so that my death actually becomes beneficial to somebody. Yeah. So there are legislations and ethics and everything covering these things and how they are regulated. And so I believe that we've come to the point where we should look at it seriously as a country, because as we speak, many of our patients who need organ transplantation have to travel abroad, to have this service, because it's not everybody who would find an immediate person within their family or friends who is ready to donate a kidney to them whilst they are still alive.
Okay. Korle-Bu is 100 years this year. The country is more than 60 years. Are you surprised that we still don't have a legislation to back all of this?
Well, some of these things, it takes a certain generation or people to kind of give it life and to bring it to the fore. Okay. And I believe that this is a good time to do that, because maybe previously we didn't even have the capacity to do some of these things. So then the laws would have been redundant anyway. But then now that we have the capacity to do so, I think this is the time to seriously look at those laws and to pass them, so that it will facilitate the delivery of this service to our patients.
I asked Prof. Che this question: where are we with this legislation in terms of lobbying, in terms of ensuring that the process is fast tracked?
Yeah, so just to give you a bit of background, about around 2005, 2007, some of our predecessors, Professor Yabo and Co, started this drive and wanted to, but it didn't go too far. And so we've taken it up again. Okay. And so we are, the paperwork is being done, because we need to also look at all the, the medical legal aspects of things. So we have a committee that's already working on this, and we've approached some of the members of the Parliament Select Committee on Health, so that so we are going to formally invite them and engage them, so that they understand, what we are trying to, which law we are trying to pass, and then they also bring their expertise to bear on it so that it can then be appropriately fashioned out and then go through the necessary stages so that it can be passed as a law. Okay. So this is just to kind of sound them out. We've done some informal work on the ground just to sound out some of the key stakeholders. Okay. But this is something that I believe is of national importance, and so we need to consider it seriously.
So in the absence of a grand legislation, what kind of law is backing the kidney transplantation?
Yeah, so at the moment, we have an ethics committee that looks into this, because one, we do not want a situation where somebody is donating a kidney out of coercion or out of financial inducement. Okay, because they need to really understand what they are doing. We want it to be done ethically. I'm sure if those who follow international news have found a situation where in the UK, some people are being jailed because they brought in somebody to donate an organ through financial inducement and all that. So there are some ethics, and we are respecting the ethics, and so we are doing our part now, even with the living-related donor transplantation, to make sure that it is not being done out of coercion or out of any inducement. So that is what we are doing, so that we stay within the ambit of the law. But then, when there's enabling legislation that is passed, then what potentially that does is that it makes potentially it gives access to a huge number of potential organs, because if a lot of people sign up to this organ donation thing, that means that you have many more organs that can be harvested, and then once people are already matched, their blood type, etc. When an organ becomes available and is harvested, it's already put in the database, and the people who match, it's determined, and then they can quickly be brought in, and then the transplantation is done for them. So that's what happens elsewhere. And I believe that Ghana, we are at the point where we can also do the same.
Okay. This is still the Lowdown on GhanaWeb TV. My name is Daniel Ojo. Today we've been privileged to speak to the CEO of the Korle-Bu Teaching Hospital, Dr. Opokuwari Ampoma. We've been speaking broadly about organ donation and the legislation that backs it. When we return from our break, we'll talk about the capacity to harvest and how we ensure that there's no abuse in the event that there's legislation passed about organ harvesting and donation in Ghana. Stay with us. We're back after this break.
Everyone needs the perfect snack to munch on during a fun moment.
Wow. Enjoy the tasty McBerry Twist cupcakes, deliciously baked and packaged for a sweet treat.
Premium quality cakes baked with love for all, enriched in butter and milk.
Yummy.
Oh, McBerry Twist cupcakes. Simply irresistible. Try one today.
This advert is FDA approved.
Welcome back from the break. This is still the Lowdown on GhanaWeb TV. My name is Daniel Ojo. So, Doc, organ harvesting, organ donation. Do we have the capacity? Now, we know we have the expertise in terms of doing the transplant. But the next phase is to have like a blood bank, but this time an organ bank.
Yes.
Do we have the capacity to store it? Do we have the capacity to ensure that there's no abuse, so that those who are financially able will be at the top of the food chain, etc., etc.?
Yeah, so that's why from the beginning we've set up a very strong ethics committee. In fact, with this set of transplantations that we did, for instance, there was one that we had to turn down because we felt that there seemed to be an element of financial inducement. That was what was informing the donors' motives, and so that was turned down because we do not want that to become what characterizes these operations. And so in terms of the legislation, every legislation, once the legislation is passed, it will give guidance to how things should be done properly. And in terms of capacity, we continue to build capacity, and we are grateful that the Fair Sky Group has generously offered to sponsor further training for some of the younger generation of doctors. And so there are going to be a lot of younger generation of surgeons who are going to be trained in these transplant techniques and all that, so that as the service expands, they'll be able to cope with the numbers, and that we'll be dealing with.
Okay. Specifically on kidney transplantation, kidney transplant, are we entering into a dangerous zone where a lot of our younger working people are having this kind of disease, kidney failures, kidney not working properly? Is it a danger? Do you worry?
Yes. Okay. So if you look at Ghana, for instance, I think the population rates, it's about 13%. Of the population have some kidney challenges, and so that is, of course, a cause for concern. Now, in our environment, some of the issues that have arisen are abuse of various medications or abuse of herbal preparations and various other things. Of course, some can be caused by certain types of infections and other conditions. And so that's why it's important that we have a screening program. Okay. So now, for many young people, the first time they did a kidney function test is maybe when they were being employed. Yeah. But many times we don't have a consistent screening program for different sections of our population, and that is something that we have to emphasize, because for the kidney diseases, they can be picked up early. Okay, and when they are picked up early, you can put in place some strategies or some interventions that will slow down the progression, even if you cannot stop it completely, but you can slow down the progression. See, what's happening is that by the time you start having frank or obvious symptoms of kidney failure, that means that most of your kidneys are gone. Like I said, if somebody can donate one kidney and still survive on one kidney, that tells you the kind of redundancy that God has built into our system. So for you to start showing signs of kidney failure, that means that more than 80% of your kidney capacity is gone. You see, but then if we are able to pick it up, the early signs, there's signs that will be seen in your urine. If you test the urine, there are signs that will be seen in your blood. If you test the blood, that will show that no, there's something going wrong, and a further test can be done, and then interventions can be put in place to make sure that whatever it is that causes it is not progressing, so that you can live a relatively normal life. But then, because we are not taking some of these screening programs seriously as a country, then that's where there's a challenge. And so that's why we also want to encourage that even with our health insurance or various other insurance policies that are put in place, they should also look seriously at covering preventive health, meaning that, like, when you reach a certain age, there are certain screenings that you must go through to pick up on certain potential conditions that could affect you at certain ages. And so once we do that, then people can come in for those checks at certain times. But the way our system is now, most people will really go to hospital when they are sick. In fact, sometimes even we, the healthcare workers ourselves, we also need to be conscientized, because if you show up at the clinic and say, "Oh, doc, I want to come for a checkup," they say, look at you like, what's wrong with you have nothing to do, that kind of thing. But we must encourage people. It's just like how your car doesn't have to be broken down before you take it for routine maintenance, routine services. So that's how we should look at it, that we should encourage people going for routine health checks, health screening, especially when you get to a certain age, about 40, there are certain things that should happen. But we can see that most of the population, or our population who have kidney problems, range between the age of 20 to 50. So they are relatively young people, and so this condition actually really reduces their life expectancy when they are supposed to be in their most productive years, and that's why it's an important condition that we must all look at addressing. Is it hereditary? There are certain hereditary conditions that can result in you having kidney issues. So there are some conditions where you have a lot of cavities or cysts in the kidney. So so there are some of those inherited conditions, but those ones, an ultrasound will pick it up. Ultrasound, the kidney function test will pick it up readily easily. So it's most of the times because people haven't had access to any serious medical, thorough medical examination, and so some of these things are missed.
Okay, I hear drinking a lot of water is good. What other things can we do to improve our kidneys?
Yes, so yes, drinking a lot of water, and regular exercise, good diet, and all those things are very important in having a good, kidney function. And if you notice, there are some things that are big red flags. If you notice blood in your urine, it's a big red flag. You should report immediately. If you notice that your urine is become very turbid, or the color is you passing very dark colored urine. It could be dehydration and other things, but some of those, looking at you, or if you urinate and you see that ants seem to be floating around your urine.
That's why they say the diabetes people are the ones who have.
The diabetes. But see, there are some of those conditions that affect the kidney.
Okay.
And then, like for young people with uncontrolled hypertension, because when you have uncontrolled hypertension, it can also affect the kidneys. Whereas it's also true the other way around, that if you have poor kidney functions, it can also make your BP go up. The reverse is also true. Okay. But those are some of the things. So I think that generally maintaining a regular, healthy lifestyle, good diet, exercise, make sure you hydrate well, because we are in a tropical environment. You sweat a lot. Some people will go long hours not even drinking a lot of water. But you need to hydrate yourself, because hydration is good for the kidney. It helps to flush out any of the toxins from your kidney. Okay.
So how many of these transplants have we done? I know the July one was the one which is wholly Ghanaian, but do you have an idea how many transplants we've done?
I don't have the numbers on top of my head. We've done a number of sessions. So usually we do, some of the sessions they've done like 4, others they've done like 2, 3. Okay. This one we did 2. We were going to plan to do 3, but the third one was cancelled for the reason that I stated. Yes. But this time we are now going to have it regularly. So we are planning that session in August. Okay. So this is going to be done on a regular basis from now on.
Okay. Is this disease a strain on the cafes of Korle-Bu, on the national cafes for healthcare?
Yes. When people have got chronic kidney disease, it is a huge strain on their family finances, primarily, because if you need to come for 3 sessions of dialysis every week for the rest of your life, and you are paying even the average, our figures are even on the low side, between 500 to 600 Ghana cedis per session. Now, how many of us even earn that as a monthly income? So you are doing 3 sessions every week.
That's an average of 1,008 to 2,000 cedis.
Exactly. And then, of course, that's just a dialysis. There are other medications and things that you'll be taking. So that's quite a huge cost. And that's how come a lot of the patients were dying, very prematurely, or some of them, they were exhaust. Yeah, exactly. Because they exhaust all their family, financial resources, and then they just give up and die. And that's why the intervention by the First Sky Group was really, really, really God sent, and has helped sustain the dialysis program over the last about 6 or so years. Okay. And so we are very, very grateful to them. But then, you can also continue dialysis ad infinitum, perpetually. So there has to be an exit point, and the exit point is having a transplantation program, so that yes, you use dialysis to tie them over a certain period, but then the exit point is when they're able to get access to a kidney transplant. Then they have a functioning kidney, and they do not need to be on dialysis any longer. And so that is the exit point, and that is more cost effective. Okay. And at the moment, health insurance does not cover that dialysis, so patients have to find a way of making it themselves, and so that is where it becomes a huge challenge. And the first kind of intervention is really, really, really critical, and has been very, very helpful. Now, one of the reasons why we need to commend them is that there are a number of patients who maybe somebody, let's give an example. A pregnant woman comes in to deliver. Okay, maybe she loses a lot of blood through the delivery, so that can cause an acute renal failure. Okay. Or a young person for some reason has an acute illness, and temporarily the kidney is malfunctioning, so they need a couple of sessions of dialysis, and usually the kidney recovers, and then they are back to normal. They don't need to be on dialysis anymore. But then in that period, an acute period, maybe they'll need 4 or 5 sessions of dialysis. Okay, the family may not have that money to be able to support the dialysis. And so it means that person will die, and people will say, oh, this is killed. But then we know, those of us in the system know that, look, if they had access to dialysis, they could have pulled through that illness. Okay, so the first kind of intervention has helped us to put like a sort of safety net, so that for those who come in with this acute renal failure, who or otherwise have survived if they were, you know, in a resource, well-resourced setting. They benefit from the First Sky program. We put them on it, and you know, they recover, and then they are on their way home. There are no questions asked. But because, you know, it comes in at a very critical point where you don't have time for relatives to go cap in hand begging. You know, you need it, and if you need it ASAP. And so it's very crucial. So that intervention has really saved a lot of lives, because a lot of the people who are you know, victims of acute renal failure, it ties them over, and then they are on their way home. Many of them have made a very good recovery, and they are living their normal lives. So we are really grateful to them.
Okay. Finally, Doc, one of the critical issues in the last couple of months has been the exodus of medical personnel from Ghana to other better developed economies. As the CEO of the referral hospital and the biggest teaching hospital, is this something that is affecting the operations of
well, definitely. I mean, especially, it's not just about the number of people, but it's the caliber of people who are leaving. One of the, most of them talk of doctors, okay, but one of the key cadre of staff who are leaving, that is really worrying, is our critical care nurses. Because, you know, when people are in very acutely ill and they need to be intensive care, high dependency wards, you need these critical care nurses. You know, they are the backbone of the intensive care units. And so if you have even just one or two leaving, that's a huge you know, big loss. And we've seen a number of them living within this period. So that is quite worrying and quite disturbing. And so we've been engaging with the ministry and other stakeholders to see if we can find ways of improving the incentives that are given to this, because at the end of the day, it's they are most of the time it's an economic decision that they are taking. And so as a country, I think we need to look at it again and prioritize you know, the compensation that healthcare workers receive. Because, you know, after COVID, you know, a lot of the health workers in the developed world are resigning or are looking at other pursuits, you know, and because of the kind of trauma that the people went through, the loss of so many lives, etc. And of course, all along or over generations, there's been that need, but it has become now more acute, and a lot less people are going into you know, some of these areas in abroad. So there's a big gap, and also they have an increase in the aging population in the high income countries, and so they need a lot more you know, personal care, and so that has driven the demand for you know, healthcare workers you know, to come from, of course, because they have more economic clout. So they end up drawing people from and developing nations like ours. And the other thing is also because our staff are well trained. We have good caliber of personnel, so that's why you know, they are like hot cake. When they go there, they readily, you know, get jobs and they fit in very easily because they've been well trained. And so I think we all need to look at as a nation and confront this challenge head on. You know, make sure that we are incentivizing our healthcare personnel, doctors, nurses, pharmacists, all the other cadres, of even radiographers, for instance. You know, we don't talk about them, but they are also an important cadre of staff who are also in critically short supply. So I hope that you know, governments and, you know, all the powers agencies you know, would look at, I mean, would work with us to you know, improve the compensation package for these cadres, so that we can have more of them stay. The other option too is also to see it as find out a way of, instead of owning it, so that we can have arranged programs where people are going on sort of some kind of arrangement, so that they are not just leaving randomly, but they are going on an arranged basis. I think something like that.
Like the Cubans do.
Cuba, Barbados, you know, you know, so that then once it's an arranged and they're going there for maybe a certain period of time, and then they are going to come back. Then it doesn't hurt the stem so much. But then we should also look at improving our capacity to train, okay, and you know, because we talk about high unemployment, but once this is also something that we can look at and make sure that then we can open up the training you know, centers, you know, and enhance the you know, the ability of our training facilities to produce more people, so that at least we don't miss out. But of course, we also need, it's not just churning out the numbers, but we also need to retain the experienced ones because you get more worried when the experienced ones are out. Because yes, you can get a certificate today, but it doesn't mean that you've got all the competencies. So you need to make sure that the experienced ones are being retained and and being helped to achieve. Get fulfillment in pursuing a career within this country.
Okay. Thank you very much, Doc. Thank you for your time. I know you're a very busy person, but thank you for opening up your doors to us, and congratulations to you and the team for what you're doing with organ transplantation. It's something that is very dear to our heart at GhanaWeb, and we're going to be with you every step of the way and see how it progresses. I know there's a new block coming up, a new ward, hall, or if you like, facility to make it more bigger. So we're going to be with you every step of the way. Thank you very much. I've been speaking to Dr. Opokuware Ampoma, the CEO of Korle-Bu Teaching Hospital. He's been opening up, talking about organ donation in Ghana as we continue our series. My name is Daniel Ojo. We'll be back another time with another edition of the show. Until then, it's bye for now.